morning, everybody, and thank you very much for joining us. Welcome to Neuroscience Research Australia and to the launch of the Lancet Regional Health Western Pacific Dementia Series. I'm your MC for today. For those that haven't met me, my name is Carol Renouf. I'm the Executive Director of Professional Services here at NeuRA. So together with the Lancet, we're very proud to be sharing with you these just released, literally at midnight last night, insights from expert reviews of the very best scientific and clinical evidence regarding risk reduction, diagnosis, treatment, and care in dementia, which I would consider perhaps the greatest societal challenge of our time as we transform from aging to aged societies. I'm also delighted to have a really multi-sectoral audience here today. Leaders from the pharmaceutical industry, academia, health, and community, because that's what it's going to take to solve this problem. But firstly, before I go any further, let me invite Lauren Poulos from our Aboriginal Health and Ageing Research Group to do the Acknowledgement of Country.
Good morning, my name is Lauren Poulos and I'm a Biripi woman working as a project coordinator in the Aboriginal Health and Ageing team at NeuRA. So I'd like to respectfully acknowledge the traditional custodians of the lands on which we meet today, the Bidjigal people, and it's important to honour their enduring connections to this place and recognise their heritage and custodianship. I'd also like to pay respects to elders past and present and extend that respect to any Aboriginal and Torres Strait Islander people with us today. Let us take a moment to reflect on the meaning of place, and doing so recognise the various traditional lands on which we do our business. We extend our heartfelt gratitude to the Bidjigal, Arpurus, Dharawal, Gumbaynggirr and Dunghutti communities for their ongoing support and collaboration and partnership. It is with deep respect that we recognise their enduring connection to this land and their invaluable contributions to our shared work. We are honoured to work alongside such vibrant and resilient communities and are committed to honouring and upholding their tradition and values in all our endeavours. So we recognise their continuing connection to the lands, waters and culture, and it's through their enduring wisdom and guidance that we're able to come together and engage in important conversations. And in the spirit of reconciliation and respect, let us acknowledge the deep history of this land as we meet for the launch of the Lancet Regional Health Western Pacific Dementia Series, aiming to foster greater understanding and support for those affected by this condition. Thank you.
Thank you, Lauren. So now it is my great honour to invite Minister Butler to the lectern.
Thank you, Carol, and thank you, Lauren, for your warm acknowledgement of country. Can I also pay my respects to the traditional owners of these lands, to the elders past and present and emerging. It is the proper and the respectful thing to acknowledge country, but in a health setting it's particularly important as well to acknowledge the yawning gap still in health outcomes and life expectancy that Indigenous Australians experience compared to non-Indigenous Australians, and reaffirm our commitment to close that gap. Thank you to NeuRA for inviting me to be here today. I'm really excited to be back with the dementia community with whom I worked so closely many years ago as the Minister for Ageing. I see Henry Brodati here, who was a close colleague many years ago when we were working together, and newer colleagues like Tanya Buchanan, who's moved from the Cancer Council to lead Dementia Australia, a terrifically important leadership role in the health sector. But thank you all for coming together at this really exciting launch. 14 or 15 years ago, I took on responsibility for the ageing portfolio. And I just thought I'd give you a bit of a sense of where things were at in dementia back then, a decade and a half ago, how far we've travelled in some respects, and how inert some of the challenges that we identified back then are still today in Australia and in the region, as the Lancet report has identified really clearly. John Howard established this thing called the Dementia Initiative 20 years ago or so. It was a response to a call from the dementia sector for dementia to be identified as one of the national health priorities, along with mental health and cardiovascular disease and cancer. And being one of these priorities means that it is a formal part of the work between state, territory and the Commonwealth governments. It has particular accountabilities attached to it. So understandably, dementia advocates, clinicians were keen to see, given what we knew about the trajectory on dementia, to have dementia added to that. Howard, Prime Minister Howard, sort of adopted a halfway house and gave it a particular name, but didn't identify it as a national health priority. And in one of those sort of bureaucratic exercises that happens in Canberra, the Dementia Initiative fell off the edge of a table somewhere. I remember, as a very new Minister for Ageing, having an utterly terrifying meeting with the then head of Dementia Australia, or what was called Alzheimer's Australia, a certain Ita Buttrose, who said, "Now, Minister, you've taken our initiative and we want it back." And I cannot do justice to the utter terrifying way in which she said those words. And I sat down with Alzheimer's Australia, as it was then, Glenn Rees, who was leading it and then went on to lead ADI. And he was just a terrific health leader who had such a wealth of experience. And I remember saying to him quite sort of honestly and forthrightly, "No one's knocking on my door in the Parliament saying we need to do more in dementia. They're beating down my door." This is back in 2010, saying we need to do more in youth mental health, beating down my door on a range of other areas. But although if you asked parliamentary colleagues, is dementia important, they'd say of course, but they don't have a sense that we're behind the ball. Glenn and Ita took that challenge up and protested in front of the Parliament House. Ita told the very significant crowd that it was the first protest. She must have been in her 70s by then. It was the first protest she'd ever attended. I won't tell you quite how she described that experience and what she lost on the parliamentary lawns. But it led to a campaign of awareness raising, consciousness building in the Parliament, in the community, that resulted in a really substantial program of initiatives that we were able to get through, I think, the 2012 budget. And ultimately, well, this was a relatively small part of it, see dementia identified as one of the national health priorities, I think at the time the 6th national health priority. And a range of other programs that I think were recognised by ADI as globally significant. It was a really gratifying, important piece of work that we were able to do that just demonstrates the value of partnership, but also of advocacy and campaigning to raise consciousness of issues like dementia, and a reminder to us that of the myriad of challenges and opportunities that we have in health, we should never take for granted that beyond our advocacy groups, beyond our portfolio, that colleagues and people in the broader community have a sense of the acuteness of some of the things that the Lancet has identified in their report. And that experience has really stuck with me. And so coming back to the health portfolio after we were so rudely interrupted by the 2013 election result has been a real delight. And as I said, what I've found, particularly coming back to the dementia area, is that some things have changed and some things frankly haven't. And the trajectory on numbers that we saw 15 years ago are just now the reality, and we're talking about a different trajectory now to 2060. You know the numbers, and you know what they're projected to be in the mid part of the century if we don't make some very serious inroads in our ability to treat dementia. And you also know that some of those really quite alarming statistics that I first saw 15 years ago around the time taken for a proper diagnosis haven't really shifted. The experience that people living with dementia have in the hospitals has not significantly shifted. The fact that they generally spend 5 times longer in hospitals than their equivalents has not really shifted. There is much for us to do, as this report identifies. What I liked about reading this report is the update, though, to our understanding in some areas. 15 years ago, increasingly we were understanding, not just in relation to vascular dementia, but Alzheimer's and other types as well, that healthy body, healthy mind is a pretty much a truism in this area as it is in so many others. But now we understand more about the impact of hearing loss on dementia. I think the thing that I found really interesting from this report was the impact of educational attainment, which in low-income countries where youngsters and parents are not able to take for granted the level of educational attainment that we have here in a country like Australia, that is important to place on the work plan that we have with our regional neighbours. One of the areas where I think there has been some really gratifying advance after not just years but decades of disappointment has been in the area of treatment. This is something we're watching in government very, very closely after the sort of disappointment of aducanumab, seeing lecanemab and donanemab sort of progress their way through the regulatory agencies with a bit of a speed bump in Europe for lecanemab. Understanding what these disease-modifying therapies might mean for people if they are able to be identified early enough in their Alzheimer's journey is something that's really exciting. It poses very significant challenges, the numbers, the level of expectation that will be there in the community that everyone will be able to access this treatment when we know that's not the case, the impact it will have on our diagnostics system, the cost of these medicines in a very large population group, even if only a relatively small cohort is going to be treatable through these medicines. It is a huge advance on where we were 10 or 15 years ago, and maybe puts the amyloid hypothesis to bed, I'm not sure, but it is a huge advance and something that we're watching very, very closely. And the other area, I guess, that is just so important for this population is care. That has been an area where there has been a lot to be desired. I remember Henry and I doing a roundtable many years ago around the overuse of antipsychotics in aged care facilities that had led to a very significant number of preventable deaths. And I remember you saying, Henry, that you'd found people who were on more than 40 medicines in aged care facilities because of the accretion of prescription not being reviewed and deprescribed. I think we've come a long way on that with some really good work about deprescribing of antipsychotics after the initial period of someone's admission to aged care facilities. But that really sort of suboptimal, substandard level of care in aged care facilities is something we've been very focused on in our government. We've added 3.9 million minutes of care per day into aged care with our increased staffing levels. We're able to do that because we've increased the wages of aged care workers and registered nurses, finally, able to get some staffing levels that mean that people with much higher needs than was the case 10, 20 years ago in aged care are getting much more care. And we're seeing that in reduced numbers of pressure sores, of malnutrition, and also of restraint, importantly, for the dementia population. There is still much, much more that we want to do, but making sure that we are paying attention to a cohort who, when I started going to aged care facilities 30, 35 years ago, were on the fringe in a single lock-up ward at the edge of the facility, are now core business for aged care, and increasingly are now core business for the health sector as well. All of this we are seeking to wrap up into our National Dementia Action Plan. This is at the relatively final stages of its development. We now need to work with state and territory ministers, particularly given that dementia is a national health priority, but we're really looking forward to making sure that we've got a plan that reflects some of those priorities that I've just talked about, recognises the trajectory of this condition in the population, but also some of the opportunities that are there that perhaps were not really identifiable 10 or 15 years ago. But this report reminds us again that although Australia is physically an island, we are not an island. I should have thought through that metaphor before it fell out of my mouth. We are an island, but we're sort of not an island. Increasingly, the Western Pacific is... Okay, you can stop laughing now, Tanya. The Western Pacific is the most sort of interesting region of the World Health organisation. It has China, 1.4 billion people or so. It has NeuRA, at about 1,000 people or so, and pretty much everything in between. It's a very large group. It has a relatively low incidence of dementia compared to aged countries like Australia, but the trajectory is, pretty daunting. And it has, as I'm sure will be identified by other speakers, a real mix of very wealthy countries like Japan and Australia and others, and very poor countries. So we recognise increasingly our responsibilities of not just a high-income country, but a very high-income country, for us to do as much as we can to help our neighbours access some of the benefits that flow from being a high-income country. That includes using the world-class medicines regulation system through the TGA to build that capability around medicines testing and around medicines regulation, which the TGA does not just with smaller countries in the Pacific, but also some of our larger neighbours in Southeast Asia. We intend to do more of that. We're doing a lot of work in building workforce capability, again, particularly in the Pacific, either with aged care workers and nurses coming to Australia through schemes like the PALM scheme and then going back with skills, or increasingly building training facilities and supporting training facilities in country as well. But this is a terrific reminder that there's more we can do. I really enjoyed reading the excerpts from the report, particularly the 4 priority actions that were identified in the plan. And thank you for allowing me to come and join you for a little while and to open these proceedings. It's been an absolute pleasure. Thank you very much.
Good morning. I just found I left my script upstairs, so I decided to share from my heart. So, good morning, Honourable Mark Butler, Federal Minister of Health and Aged Care, Professor Matthew Kernan, CEO of NeuRA, distinguished guests, good morning again. I must first declare my conflict of interest, that although I'm representing a region from the Western Pacific area outside of Australia, I am very strongly affiliated to Australia because I graduated from a medical school in Sydney 30 years ago in 1993. So my heart, my affection is for Australia. Okay, so 30 years ago, when at that time it was Bob Hawke and Paul Keating were the prime ministers, dementia was not a major health issue. Because at that time in Australia, or back in Hong Kong where I'm working at now, the mean life expectancy was only 75 years old. And at 75 or below, dementia prevalence was less than 10%. But as Mark Butler rightly mentioned, over the decades, things have changed tremendously, especially in this Western Pacific region. The mean life expectancy increased from 75 to almost 10 years, reaching 85 years old, almost 85 for the high-income countries in this area, Australia, Hong Kong, Japan, Korea, and even for China, Vietnam. The mean life expectancy now was beyond 75, almost touching 80 years old. And once the life expectancy, and once we live beyond 75, dementia prevalence, the curve increases 75 exponentially. And once we live to the age of about 85, dementia prevalence is about 30%. So 1 in 3, if we live to our mean life expectancy in Australia, in Hong Kong, 1 in 3 will have dementia. It's scary to live long. So back in Hong Kong, I've been experiencing this dementia tsunami over the decades. Not only as a professional, I've been seeing more and more dementia patients and the families, but also on a personal level, because my father suffered from dementia, and he passed away in 2018 at the age of 85 because of dementia. And as I look back those years, as when I remember the first time my father could not recognize who I was, my tears flow down. And as I remember the stress my mother and my 3 other siblings, they experienced as we cared for our father, all these were real nightmares to me. And I hope this will not happen to me again or to anyone else in this society. So what may happen in the next 30 years? The Alzheimer's Dementia Report estimated that the dementia prevalence will continue to increase and even triple to 130 million in the world by 2050. And this problem will be worse in this Western Pacific region. And the greatest proportion of people living with dementia is where? By 2050, half of the population of dementia will be residing in Western Pacific region, in this region, in Australia and the neighbors in Asia. So what can we do to tackle this dementia tsunami? Yes, I agree with our federal minister, more support for the family, dementia patients, support facilities, we have more services, more educational advocacy programs. We definitely need more research to understand the mechanisms, to develop better biomarkers, better treatments, more affordable. Yes, we need all this. But to me, from my heart, I think we need one thing, one very important thing. And this is to have a competent, capable leadership that is committed in tackling this dementia tsunami. And Australia has taken up a leadership role in major health issues over the past few decades. And NeuRA is a center of excellence in dementia and other brain diseases with strong established network of professions, not only within Australia, but also outside Australia in the Western Pacific regions. And I can envision, with the support from the government, as our federal minister just mentioned, his heart for the neighboring countries, with support from the government, Australian government, with the support from leadership of NeuRA, I am confident, I can envision that Australia is able to make significant contribution in tackling this dementia tsunami that other Western countries, they are not in the position, at least not in the best geographical position in tackling this dementia tsunami in our Western Pacific region. To end, it's my immense honor that I can share my story in front of the minister, in front of the leadership of NeuRA, in front of all the distinguished guests, philanthropists, researchers, or even students, or other dementia advocacy personnel. And I have full confidence that all of you actually shared my vision as well. The vision is longevity without dementia. And I'm confident that this vision is within our reach, within our lifetime, if we have the leadership and partnership together. Well, may I wish every one of you a good brain health, for it brings health. And also actually today is our Chinese Mid-Autumn Festival. But try not to take a lot of those lotus mooncake. They are not good for your brain health. Thank you very much. Thank you.
Thank you, Carol, and thank you to NeuRA and the Lancet Group for inviting me to speak today on the risk factors for dementia in the Western Pacific region. And we've already heard just this morning there is a dementia tsunami coming, but I'm here to tell you the good news, that nearly half of dementia cases can be delayed or even prevented by early and better management of modifiable risk factors. These factors are a dynamic interplay of the biomedical and lifestyle influences, as well as socioeconomic influences across the life course. So despite the obvious demographic, cultural and geopolitical diversity in the region, and that drive country-specific dementia risk factors, I'm going to highlight a couple of specific targets for the region. And we've already heard again today that access to quality early life education is one of the most important factors to reducing dementia risk. Educational inequity is widespread in the region and contributes the greatest population level risk for dementia in China, and more so in rural areas. Obesity is another major target, with over 60% of people living in Australasia or many of the Pacific Islands overweight or obese. And social isolation and loneliness are increasingly prevalent and were exacerbated by the COVID-19 pandemic. There are also risks we don't know enough about. Our understanding of the genetic factors at play with Alzheimer's disease is growing, but there's a greater need to diversify our genomic data to better understand molecular risk. And additionally, there's insufficient understanding of the cultural or ethnic factors influencing the detection and treatment of dementia, particularly the frontotemporal dementias. Even with adequate detection of dementia, much of the Western Pacific region is under-resourced to manage the increase in cases. As we transition to those aged societies, the time is now to implement a whole-of-society approach to lifelong brain health. There is great potential for policy and research collaboration in the region. We've already heard that experiences of countries with older populations and established dementia cases can be used to guide locally adapted models of dementia prevention and care. Inclusion of ethnically and culturally diverse populations in large-scale longitudinal studies will contribute to more robust data. And underscoring these partnerships are the community-level actions needed to age well. Positive health messaging should encourage protection of brain health, with, to use those earlier examples, continued education through engaged employment as well as early learning, regular and enjoyable physical activity as a means of combating obesity, and social connection as a human imperative. By fostering multiple opportunities for good health across the life course, every individual in the Western Pacific region can expect to age well. Thank you.
Thank you, Carol, and thank you to the Lancet and NeuRA for this opportunity to be here today. I'm Rachel and I work in the area of neuropathology, and I'm just going to talk about a particular area. So pathology and what I'll refer to as microscopic changes in the brain, we know that this starts to happen in patients years to decades before they become obvious through symptoms like mild memory loss, cognitive changes, and eventually dementia. And through the study of postmortem brain tissue, we've been able to find out what some of these microscopic brain changes causing dementia are. And this knowledge has grown and evolved over the last 45 years with research and new discoveries made. And we now know that the type of microscopic change and its location in the brain influences a patient's clinical presentation, their disease trajectory, and also the types of drugs that would be relevant to them. And most of this knowledge has been made possible through the study of brain tissue donated to brain banks predominantly located in Europe and North America. And up until very recently, we've largely assumed that this knowledge derived from these brain banks are applicable to almost all individuals living with dementia across the globe. But the last few years alone has seen this increasing body of evidence demonstrating that the types of brain pathology causing dementia in individuals living in different countries, as well as in individuals with different racial and ethnic backgrounds living within the same countries, differs. So this has important implications for both developing relevant therapies and also diagnosis, and it really emphasizes the need for us to find out what the brain changes driving dementia are in the Western Pacific region, because the Western Pacific is home to, as we've heard this morning, 36 diverse countries and territories that collectively will contribute to over 50% of the number of individuals living with dementia by 2050. So over the last 8 years alone, we've seen exciting progress in this region with brain bank networks being established in South Korea, Japan, and China, in addition to that already established here in Australia and New Zealand. And Japan and China, again, as we've heard this morning, are the two most populous countries in the Western Pacific. So this really represents a significant step towards trying to find out what some of the pathological underpinnings of dementia are in a large proportion of individuals living in the Western Pacific. But despite this growing capacity and knowledge, there is significantly less data and knowledge on the prevalence and underpinnings of dementia in the remaining 33 countries in the Western Pacific region, including in countries where populations are more prone to dementia because of various socio-economic factors, which we've heard from Antonia this morning. Our review demonstrated that of all of the Western Pacific research, all of the research coming out of the Western Pacific, over 80% of them are from three main countries, Australia, China, and Japan. And so it really highlights this need for us to increase collaboration to find out what the underpinnings of dementia, driving dementia in this region are, so that we can better develop better therapies that are relevant to and help to mitigate this growing burden in this large region that we're a part of. Thank you.
Thank you, Carol, and thank you to the Lancet, and thank you to everyone for coming here today. So I'm going to talk to you about a topic which is really exciting and we've waited a long time to hear about, and that is treatment for dementia. So we're now entering this sort of new, rapidly evolving era for disease-modifying therapies for dementia. And that's particularly true for Alzheimer's disease, as we've now seen 2 drugs that actually can lower the amyloid protein come to market. These drugs are available in China, Korea, and we hope that we'll hear soon about their license in Australia. And from our review, we know that Alzheimer's disease, along with vascular dementia, is the commonest cause of dementia across the entire Western Pacific region. So these new therapeutics are really relevant to us. And it's our challenge to strive for equitable access across the region and to ensure that this new era doesn't further increase the health disparities across this region. So what are the barriers to effective therapeutics in the Western Pacific region? Well, first of all, it's cost, and this is a global issue, really. The drugs are expensive, monitoring them is expensive, and it places this increased burden for capacity on the health service in general. Secondly, we know that how we diagnose these disorders is also evolving. So we now have pathologically targeted treatments, so we need a pathological diagnosis. And that means we need access to expertise in terms of personnel and also specialised equipment. Stigma of dementia and the symptoms related to dementia is a huge barrier in the Western Pacific region. And we need to really address this to ensure all of our population have access to services which can allow them to receive an appropriate dementia diagnosis. So what can we do? Well, first of all, we can raise awareness and educate our population. And we can do that by pulling together our resources, our expertise to drive policies, and that's already happening. We need to do more. Also, in this region, we have a wealth of scientific expertise in this area. And, we really need to work together, thinking about our unique population. How can we develop accessible, cost-effective biomarkers of disease that we can roll out to our population? Similarly, we're seeing from some of the data on these new drugs that there may be racial differences in terms of how people respond to the drugs, and also in terms of risk of adverse effects. So again, we need to come together as a scientific sort of research community and work out how we best approach this for our population. And, this is just the tip of the iceberg. There's going to be a tsunami of therapeutics coming as well. And I think we really need a collective approach to both diagnosis and treatment across the region, and that has to encompass the sort of wealth of ethnicity, race, culture that we have in our Western Pacific region. Thank you.
Thank you, Carol and NeuRA, for the opportunity to present today. So as we've already heard, the Western Pacific region faces several health challenges, particularly increased prevalence of non-communicable diseases, climate change impacts on health, and frequent threats to health security. Non-communicable diseases are the leading causes of death and disability in our region. 1/4 of global non-communicable disease deaths occurs in our region, and this is projected to increase further in the future, as we've already heard. These diseases are becoming more prevalent due to many factors, particularly rapidly aging populations, urbanisation, and lifestyle changes. In particular, the increasing prevalence of dementia in our region poses many health challenges for people living with dementia and their families, caregivers, and society as a whole, with regards to risk reduction, diagnosis, treatment, and care. These health challenges do not affect individuals and communities uniformly. As we've already heard, social factors such as education, employment status, income, gender, and ethnicity influence health status and outcomes. Addressing health inequities is imperative to effectively reduce the burden of dementia in our region. This series, published in the Lancet Regional Health Western Pacific, reflect the Lancet Group's values. That is, the right of every person to health and healthcare and health equity. The ultimate goal of the regional health journals is to improve health outcomes by advocating for equal access to quality healthcare and advancing research, clinical practice, and health policy in all regions of the world. For the Lancet Group, advancing equity, diversity, and inclusion is a commitment to health for all. We strongly believe that medical journals have a responsibility to advocate for underrepresented groups and challenge biased, exclusionary systems in research, academic publishing, and clinical practice. Together, and in partnership with people living with dementia and their families, healthcare professionals and policymakers, we must focus on generating evidence-based programs and policies tailored to the diversity of our region and with respect to culture, socio-political histories, demography, economic situation, and health status. This series calls for intersectoral collaboration and action to address disparities in dementia risk, incidence, diagnosis, treatment, and care to enable the best level of health for all people in the Western Pacific and globally. Thank you.
Antonia, I read with interest in the papers this pretty horrifying statistic going to education, that 20% of children under 10 in the region are unable to read or understand simple text. Where do we go from there?
Yeah, it's a pretty horrifying statistic. But I think if you flip the way we look at that, there is so much opportunity there to address that particular risk factor. And I think when we're talking about dementia prevention, it's nice to have that reminder that it is the development of dementia is multifactorial, and that means there are many, many opportunities along the life course that we can address dementia risk. Traditionally, we have focused in research and policy on those biomedical and lifestyle risk factors, so things like I mentioned obesity or hearing loss or alcohol use. But I think the targeted management of those risk factors needs to occur alongside consideration of the structural drivers behind them, education being one of them, financial hardship or economic hardship being another, and access to quality and affordable, good, primary care. And most importantly, I suppose, when you look at health inequity like that, addressing health inequity on that broad level means that you can improve the ageing process across multiple domains, not just with respect to dementia.
Thank you. One over here, Glenda. Professor Glenda Halliday.
Emma, they're already rolling out dementia targeted treatments in Asia. Do you know who's getting it? Is it equitable? Do you know if how effective it is already, or is it just starting? So we heard that the therapies would actually only be able to be a fraction of people that might get it. So it'd be really interesting to see what's happening in our Asian systems.
Thanks, Glenda. Yes, as you said, these new sort of pathologically targeted drugs it's only really starting to take off. And we have two at the moment, lecanemab and donanemab. As you said, they've been established in the US for a little while longer. And we're waiting to hear about Australia. But yes, they've been rolled out in China, they've been rolled out in Korea. My understanding is, actually I met one of the neurologists involved in the Korean rollout a few months ago. And similarly, there has to be a selection process so we can choose the right people that are going to respond to the drugs. And similarly, my understanding is it's a government funded sort of scheme, and again there is a sort of a rigorous process involved in selecting people. So that includes, like I briefly mentioned, having a pathological biomarker to confirm the disease. And that can be PET imaging, or that can be CSF, identifying the amyloid and the tau proteins. And I guess how that's going to look in the future, I think it's a bit too early to say. But certainly I think it raises a lot of issues in terms of how we roll this out in the health sector. How do we manage this increased sort of burden and capacity? And I think all of that is going to be a challenge. But I hope that it will be worth it, you know, and I think this is actually really exciting, and you know, we're going to see a whole lot more in this area, and it's probably not just going to be one drug that's, you know, the magic bullet. It's probably going to be a combination of therapies, and how we manage that will be a new challenge as well.
Thank you. Toby Wilson, I haven't prepared you for this, so I hope you don't mind me putting you on the spot. Andrew, could you give Toby the mic? Just curious, as Chief Executive of our health district, how are we preparing for these changes in infrastructure, workforce, etc., which the Minister mentioned are going to be so challenging?
I think it's very early days for us at the moment. I think this is part of the importance of the collaboration between UNSW, NeuRA and the district to actually understand what this looks like. Some of our senior clinicians are actively involved in processes with NeuRA at the moment to work through what this would actually look like. But I think from my perspective, it's still really unclear. We don't understand exactly how this is going to roll out, what that's going to look like, and what therefore the resource requirements are going to be, are going to rely on. And it's unfortunate the Minister has left us, because part of the challenge around this is also how the existing funding models support some of these things, because some of those tests that are going to be required to be eligible for this are not necessarily the tests that are funded at the moment. So there's a whole complex environment that we're going to have to solve for to be able to address that.
Work in progress, yeah?
Absolutely.
Would you mind passing the mic to Professor Cheryl Jones, who's next to you? Another one out of the blue, Cheryl. Something else interesting that I read in these papers. So dementia research accounts for less than 3% of total health research output across all WHO regions. Is there something that universities could do about that?
Absolutely. I think that, and particularly at precincts like this, where there's integration of health with the university, with the medical research institutes, it's an incubator for priority-driven research. And we've already heard for our region and internationally that this is a top health condition, a non-communicable disease that we need to prioritise. And that can go all the way from discovery science through NeuRA, through to broader research at the university, but also testing models of care through the local health district and with our health translation hub as well. And that will always follow on for education programs, and more broadly we've heard the importance of, that Antonia had mentioned, of early interventions for education and other social determinants of health. So how better than an institution that's driven to promote education to be part of that and linking out through regions as well.
Thank you. I think I forgot to say Dean of the Faculty of Medicine and Health.
33 months.
Maybe people guessed that. Thank you. And it was very kind of you to sit together. That made it most convenient. It was a complete accident, but thank you. Okay, back to our panel. Rachel, I had a question for you. I was interested, you touched on how the pathological changes differ in patients from different racial and ethnic groups. Do you want to elaborate a bit on that?
Yeah, so thanks, Carol. So this just started back in 2019 when a brain bank started collecting brain tissue from individuals of different heritage. And what they found was that despite, and this came from work from America, that despite African Americans being twice as likely to get dementia compared to other groups in America, they actually had a lower burden of a lower increase in tau pathology in your brain, and they also had another type of pathology called hippocampal sclerosis. And this was really interesting information, but what this has resulted in earlier this year was that a few studies published that clinical trials are now saying that certain ethnic groups are not eligible for these clinical trials because they have a lower burden of this pathology. And so this really just demonstrates, like in our review, we looked, there wasn't really a comparison between the brains and individuals of different heritage in the Western Pacific region. That data hasn't been, that work hasn't been done yet, but we see differences in the prevalence of different types of genetic mutations, and genetic mutations give us some sort of an idea into what types of pathologies there are in the brain in a subset of patients with dementia, and we see differences in our review in the types of pathologies that there are in individuals from different backgrounds. And so that suggests really that for us to move towards better being able to target the brain pathologies and give relevant patients relevant treatments, we really do have to understand what is driving dementia in the different populations that live in the Western Pacific as well.
Thank you. Other questions from the floor? Over here.
Thank you. I'm Henry Bradati, and I work at the Centre for Healthy Brain Ageing here at the university. We had the welcome to the country. We haven't talked about Indigenous people or First Nations people in Australia who have a much higher rate of dementia, and a lot of the issues that are raised as far as the Western Pacific, we have to look internally as well as externally. I haven't read the report yet, so I presume it's been addressed in that, but I just wonder if the panel would like to talk about that.
Thank you, Henry. Interestingly, one of the things I picked up in the report, which I didn't know before, was that in Australia, up to 40% of Aboriginal and Torres Strait Islander children have otitis media, and which makes them one of the most at-risk groups for hearing loss globally, hence dementia in the future. Antonia, I know this has been a particular interest, I think, of yours, the Indigenous population.
Yeah, and I think, thank you for your question. I think it is important when we're talking about the Western Pacific region, we're not just talking about countries within the region, we're talking about areas and populations within each country. And, you know, that for Australia, that means discussing and thinking about Aboriginal and Torres Strait Islander peoples, the first peoples of Australia. And as you've mentioned, Carol, there are a number of risk factors that are more prevalent in First Peoples compared to non-Indigenous Australians. And those span the life course. Again, otitis media, but also vascular risk factors. There is scope. So you know, I've talked about addressing those structural drivers behind those biomedical risks, but there's also scope to think about protective risk factors. And some of the work I have been doing through Monash University is looking at what helps the brain to age well. Social connection to kinship and family, all of those things are really good for brain health and really prioritised within Australia's First Nations people. So again, expanding the scope of our research and policy to look at promoting those protective factors is important.
Interesting. Another point, perhaps, you know, related, but I might throw this one to Jazz, actually. I read in the report about, in a number of the low to middle income countries in particular, but this would also apply to our First Nations peoples, the prevalence of filial piety and elder care as two critical values that these cultures hold on to. But it's protective, but in a way it's problematic because it also absolves the rest of us from doing much about it. Jazz, what do you think?
Yeah, I think, one of the main priorities from an editorial perspective that we're going to focus on is models of care and also health system strengthening. I mean, the rapid increase in dementia, we are underprepared in terms of, you know, how do we support not only people diagnosed with dementia, but also their caregivers who tend to be the main carer for people living with dementia. So that's going to be a major focus going forward for us, and also in terms of lower middle income countries, you know, the percentage with universal health coverage is not, it's still quite low. So how do we get, you know, people diagnosed, as in Sharon's review, how do we get timely diagnosis, treatment and care to people living in rural regions, for example, or very vulnerable populations? I think that's going to be a very key, you know, research question that we need to focus on.
Thank you.
The Lancet viewpoint, which really brings all of this together, builds on the WHO Global Action Plan for the Public Health Response to Dementia. And critically, it argues that we need a multi-sectoral approach to address the complex challenges that we face. Now, WHO has set a target of 75% of countries having a national dementia action plan by 2025. In our region, only 11 countries currently have a plan, so that's an area where we need to work together to bring around more national dementia action plans. And of course, we're all very much looking forward to seeing the release of the Australian plan, hopefully very soon. The viewpoint also reflects the WHO Global Action Plan's 7 areas of action, and they include making dementia a public health priority. So it's already a clinical health priority, but it needs to become a public health priority. Dementia awareness and dementia friendliness, dementia risk reduction, dementia diagnosis, treatment and care, support for carers, information systems for dementia, and dementia research and innovation. Related to our regional development in the area of dementia is recognising the strengths of specific cultures and being willing to work with people and learn from areas, whether it's risk reduction, whether it's neuropathology, whether it's systems of care, whether it's implementing AI, learning from each other and not assuming that we always have all the answers. Strong social networks and connections and sense of community are a strength of many of the lower middle income countries and communities that we work with. However, there's a real need to increase dementia literacy amongst health workers, governments and the general community. Improved understanding of dementia science and prevention will reduce dementia stigma and improve the dementia friendliness of cities and societies. Issues, as we've already heard today, specific to lower income countries relate to the lower rates of diagnosis, the limited infrastructure and health workers. So really the viewpoint calls for the establishment of a regional task force for dementia that will enable greater collaboration in health system design, systems, pipelines and protocols to implement advances in diagnostics, advanced therapeutics, the use of assistive technology to meet demands to deliver care at lower cost, innovations in AI, data capture and measurement and research. And all of this will hopefully accelerate progress in the intersectoral approach to dementia over the next 5 years. Thank you. Over to you.
Well, thanks, Carol. And I think we've heard so much about the Western Pacific this morning and all the important intricacies and the diversity of backgrounds, of experiences, of care, of networks. And really, I think that was the sort of the focus that the Lancet brought to this discussion. The Lancet said that they wanted to shine a spotlight on this region and ultimately to try and improve outcomes for people living in the region. And I think it was a great vision from the Lancet to bring us all together in a constructive way. And so we focused on trying to outline the current situation, and that was covered by each of the panellists this morning. And then we brought all of the authors together to really create a roadmap for the region. And I think that is the strength of today's proceedings. And that roadmap incorporated the World Health Organization's blueprint, but particular focus on the Western Pacific. And the first issue that we've covered is obviously that the dementia is a huge burden and it's a crisis for this region. And what can we do as a community and as a region to address it? Fortunately, 40% of the risk factors for dementia are modifiable. So if we can focus on those modifiable risk factors, which have ranged from education through to vascular risk factors, blood pressure, smoking, reducing excess alcohol intake, looking after blood sugar levels, treating depression early and effectively, maintaining social integration, and working as a community. These are key parts. These are all modifiable, and this is within our power as individuals and as a community to take forward. We've also realised that we need to build capacity, and that is at both a care level, so multidisciplinary care, and those models are different throughout the regions, but we need to support, and I think the developed countries need to show the leadership to try and grow this in an effective manner in a global community. We've heard about the introduction of monoclonal antibodies, and I think that's why it's critically important that we have policy makers here, we've got industry, we've got community, and we need to work out equitable ways to bring this treatment forward and make it available for those patients who need it. But I think it's been great to see the connection of research with health, with the community and education. And I think that's the critical measure, the critical message, that we need to bring forward information technology systems. And I think that the brain bank, which has been developed here at NeuRA, which is a national and global resource, and there are so many things that we could do for the region and that we are currently doing, taking this forward. But we need policy to bring these key stakeholders together and then support. So the brain banks across the region are very few, but they're very expensive. And can we support this with policy to come up with better mechanistic insights into dementia, and then with that focused treatment plans and precision treatments for everyone that is affected by these conditions. So I think it's been a wonderful morning and series of discussions, and I think all of the authors are proud of the roadmap and also the fact that we got the cover illustration on the Lancet, and we'll be rolling that out, and I'll hand it back to Carol. Thank you.
Well, thank you, Carol, and can I just congratulate the Lancet Health and NeuRA for bringing this wonderful collection and this event together. I mean, how do I sum that up in 5 minutes? So what I would like to do, though, is start by thanking the Honourable Minister Mark Butler for his obvious leadership and commitment to addressing dementia outcomes in this country. It has been very timely, I think, to hear from our speakers today, as it's National Dementia Action Week. No accident there. And as our speakers have detailed and discussed, dementia is a growing and pressing health concern, not only for Australia but for the region. And so we need to just stop and reflect that in our region, by 2050, globally, half of the people living with dementia will be in our region. And in Australia, we currently have 421,000 Australians living with dementia, a figure that's expected to double over the next 30 years. There are 1.6 million Australians involved in the care of people living with dementia in 2024. And First Nations Australians have an estimated 3 to 5 times the rate of dementia than non-Indigenous Australians. So our challenge is to think about dementia well beyond the aged care sector and start to think of this as a chronic health condition that requires a really coordinated, multi-sectorial public health approach across the life course. Now, today's speakers have detailed the challenges and opportunities for dementia prevention, diagnosis, treatment, supportive care, and the pressing need for ongoing research. And as our speakers have noted, there is a fundamental need for national dementia action plans. And here in Australia, as we've heard, we are eagerly awaiting the much anticipated any moment release of the National Dementia Action Plan. But one thing we have heard today is that all of those dementia action plans must have health equity baked into them at their core. We have heard about the need for research in dementia, and it's an exciting time to be working in the field of dementia. And so research need has never been more pressing. And NeuRA, the Lancet and Dementia Australia have a very strong and shared interest in supporting this. Dementia Australia, through our Dementia Australia Research Foundation, is committed to supporting researchers and to ensuring that the living experience of people living with dementia and their families and carers
are included at the beginning and throughout the entire course of dementia research. Now, it is an exciting time to be working in the field of dementia. We have research evidence that says a significant number, the recent Lancet Commission report says 45% of current dementia cases could be prevented into the future by addressing 14 modifiable risk factors. We are incredibly close to accurate early diagnosis, and excitingly, we have the first batch of disease-modifying therapies progressing through our regulatory processes here in Australia and already approved in other countries in the region. But people who live with dementia continue to experience discrimination and stigma because, as a community, there is a profound lack of understanding of dementia, and we hear this highlighted again in our discussions around the region. So, as Minister Butler said, much has been achieved in Australia, but Dementia Australia's own research that we released this week shows that there remains a profoundly concerning lack of awareness and understanding about dementia here in Australia. 1 in 3 people surveyed in Australia think that dementia is a normal part of ageing. 68% of people said they don't know very much about dementia, and 2/3 said that dementia is something they'd really rather not think about. Limited knowledge and understanding about dementia results in people living with dementia experiencing stigma and discrimination in a wide range of settings, and sadly, the healthcare field is not exempt from that. Which brings me to Professor Mock's comment. We must show leadership. All of us here today must do more, and as we're doing the topic of this year's Dementia Action Week, Act Now for a Dementia-Friendly Future, I implore all of us to take heed from the speakers we've heard today and to personally invest in taking leadership so that we can drive positive changes and better outcomes for people into the future. We need urgent and sustained action by communities and governments at all levels and across the region to increase awareness and understanding of dementia and to take action. Here in Australia, as I mentioned, we need to see our National Dementia Action Plan released and funded for implementation with ongoing monitoring of outcomes. It cannot be a plan that sits on the shelf. So as I wrap up today, I hope I did you justice in trying to pull that all together. A reminder that our National Dementia Helpline is available 24 hours a day, every day of the year. You can contact us on 1800 100 500. And please do share that information widely, because I hear it all the time. I wish I'd found you sooner. So thank you again for inviting me to speak. I encourage all of you to grab the papers on the way out. They're a fantastic read, and thank you for your leadership and commitment.